go ahead and start. As you all know, this is helping our kids and parents get to adulthood with chronic illness. A few disclosures: I am a consultant for several companies, as well as for the United States Department of Health and Human Services Vaccine Injury Compensation Program. As Kristen said, I'm on the Medical Advisory Board of Dysautonomia International. I did lift some of this information from multiple sources. I am, as you heard, a pediatric cardiologist and pediatric autonomic specialist. I have two adult-age daughters who are learning to adult. All right, so let's get started. So first, forget the chronic illness piece, okay? Transitioning from being a child to an adult is hard. And those of us who have done it can kind of think back to it and sort of remember there are a lot of changes, right? There's growth, there are body changes, and kids can be very self-conscious about their physical appearance. There are hormonal changes. There's increased interoception, which means being aware of what you do to yourself, or how that affects how you feel and how you behave and how and what happens to you. There's a change from concrete to abstract thinking. There is attention to sexual orientation for some, and of course, having to accept increased responsibility. And that's just within themselves. And then there's everything else. There's increased demands from school. There's negotiating friendships. Friends come and go. There's athletics and extracurriculars. There are cell phones and social media, and there's the bigger outside world. There's alcohol, there's other drugs, there are intimate connections and activities, and also thinking about what you want to do for the rest of your life. So there's much going on, many stressors. Meanwhile, on the other side of this, we have parents, right? So parents have to walk the tightrope. They um, have to give guidance and direction, but they give more responsibility. And the goal here is allowing failure in a supportive way and allowing our kids to learn so that they can take care of themselves. I have always referred to parenthood as a benevolent dictatorship. We are really not here to be our kids' friends. We're here to help them become adults and then leave. And so that's tough, right? It's hard for the parents. It's the joy and the pain of your child preparing to leave the nest. That's a tough one. And then on top of that, we're all human beings, right? We all mess up. Our emotions, fatigue, stressors get the better of us, and we really just want our kids to be happy and healthy, all of us, right? It can be difficult to give over control to your kids. That's a tough one. You've been, for the first 10 years or so of their life, if not more, you've been doing all this work for them, and they haven't had to have a lot of responsibility. So it's difficult to turn that over. And then parents can have their own issues as well. Our behavior patterns are based in part on how our parents raised us, right? And so we are products of how we grew up. Parents may have chronic illness themselves, POTS, psychiatric illness, or other stuff. Um, there's that dopamine rush of feeling helpful or important or needed as a caregiver, and that can be hard to give up. And then there can be some external concerns that can be problematic that weigh in on how we do what we do, including financial issues, how we deal with our extended family, and other things like that. And now we're going to add a chronic illness, right? And not just any chronic illness. This is a chronic illness that is debilitating. The symptoms are invisible. We have orthostatic intolerance, pain, brain fog, insomnia, fatigue, so many other, GI issues, so many other symptoms that on examination, you can't find it. You don't see it. These patients are undiagnosed or blown off by medical personnel, requiring multiple visits, multiple clinician evaluations. And it's poorly understood in general by the medical establishment, unlike other disorders like cancer and asthma and that kind of thing. And there's a wide variety of approaches for treatment and therapy, even by those of us who are quote unquote experts. Um, and then put on top of it that the therapies that we may suggest may not immediately help or may not be helpful at all. And so it can sometimes take multiple iterations to get it right. On top of that, these kids are unable to attend school often, and unable to socialize routinely. They may have more than one illness. So I think we all know that POTS does not come in a box by itself. It often comes with multiple other issues: mast cell activation syndrome, joint hypermobility syndromes, including hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder, craniocervical instability, small fiber neuropathy, median arcuate ligament syndrome, systemic lupus erythematosus, Sjogren's disease, post-concussion syndrome, and these may not be recognized, diagnosed, or adequately treated either. They can also have comorbid psychiatric disorders, anxiety, depression, etc. And they may have neurodevelopmental disorders such as autism spectrum disorder and ADHD. We just published a paper this past spring on potential genetic markers in POTS. And probably in my present clinic right now, which has been open for about 5 years, about almost 10% of my patients have some aspect of neurodivergence, including autism. So it's the perfect storm. And for those of you who are old enough or of a certain age who remember the movie The Perfect Storm, this photograph is actually from that movie. It's a combination of events in which the situation is drastically aggravated. So what can happen when we kind of put all this together? From a patient standpoint, they are undiagnosed. They're not able to exercise or haven't been able to exercise, so they're physically deconditioned. They're inadequately treated. They're unable to participate in their care. They're not infrequently abandoned by their friends. Their friends look at them and say, "You were fine 5 minutes ago. What's going on? Why can't you do this?" Or the symptoms are invisible, and they're like, "You know what? We just can't cope." And these kids are also unable to perform in school to their expectations, either academically or athletically. I think a number of us are aware that POTS patients very frequently are highly achieving, either academically, athletically, or both. From a parent's perspective, they become the chronic caregiver, and that's stressful. It's hard to see your kid really sick and not getting better and being that debilitated. Um, in a way, and I sort of referred to this before, it can be rewarding, meaning that it can put you in the role of caregiver, meaning that you are needed, but that's not an ideal position to be in. It can be difficult in getting the patient to help out and to enlist them in their own care. It can be often difficult to not, or it can be difficult to know where to set those boundaries for intervention. How much should I just go ahead and do this again tonight? And you have kind of uh, sort of the mama bear complex, because doctors have blown these kids off or not diagnosed them. Um, you often get parents, not infrequently the mom, having to really be upfront and be, in these doctors' faces and saying, "This is not, they're not making this up. This is real. You need to do something." And so it can appear like they're doctor shopping or worse, um, looking online at Dr. Google and finding all kinds of either wrong information or information that may be germane to one patient, but not to everybody. Oh, and by the way, as I always tell everybody, our kids are genetically programmed to stop listening to us at adolescence. Okay, not really, but they are trying to differentiate into themselves, and so that can include ignoring us, going against advice, taking risks, and rebellion. And as I always talk about the adolescent brain, it's a lot of gas pedal and very little brake, right? And so eventually that evens out when they get to be an adult. But again, this is why adolescents are much more risk-taking. There is much more threat and emotional of activation than there is control in the system. So, Houston, there's a problem. There's an alien in my house. I don't know who this kid is. I mean, I knew them for the first 10 or 12 years, but I don't know who this is now. All right. How do we get through this? So, yeah, it does help to have a good clinician managing care. That includes getting diagnosis and that kind of thing. But when it comes to actually helping and working with your child, straight up, we need to set expectations and empower them to take responsibility. I have found repeatedly that the patients who do the best are the ones who learn to take it on themselves. They don't have mom or dad looking over their shoulders saying, don't forget to do this, make sure you do that, do this, blah, blah, blah. They're like, I got it. Do less for them. Let consequences happen and let nature take its course. But don't leave them in a vacuum, right? Help them think through their options and work through the problem solving. Have them participate in clinic appointments and still be a team. It is important to make sure that you do set boundaries. It is important to allow these kids to spend time with their friends and even talk with their friends to help them understand what's going on so that they can be supportive in this situation. It is so important to have grace for when things go badly. It's a crappy bunch of diseases, and so being able to just say, "All right, today was a bad day. We will hit the reset button and we'll start again tomorrow." Having flexibility, right? And recognizing that some days are worse than others. Certainly planning ahead is quite helpful in this setting. Humor, if you ain't laughing, you're crying. So definitely encourage humor. It really does help get through the day. Communication is so important here. We have, as you probably heard before, we have two ears and one mouth, so we're able to do more listening. And I think the listening portion is so much more important than the talking portion. The listening, validating. You know what? I hear you. I understand. I think that makes sense. Encourage emotion. It's okay to cry. It's okay to be angry. But being supportive and involving the patient in important decisions, it gives them a sense of control. So much of these illnesses take control away from these kids. And so having them be able to have some aspect of control makes it easier for them. It helps them from a psychological standpoint. I think it's so important that we remember the loving portion of this, right? Connectedness is stronger than the disease process. It is important to make sure that psychiatric issues are appropriately managed. And I have found repeatedly in my patients that it's very difficult to manage POTS symptoms and other comorbidities if the psychiatric issues are not adequately managed. I frequently recommend counseling for chronic illness management, both for the patient as well as the parents. As I have heard Dr. Blair Grubb say, we are not born with these tools in our toolboxes, right? So, and I think there is a lot of, or not a lot, but there is some stigma about getting counseling and having some aspect of psychological support. And I think what I say to my patients, the way to think about this is, because we're not born with these tools in our toolboxes, it's like going to school, right? It's it's going to somebody who is going to teach you these techniques, who's going to give you these tools in the toolbox to help you get through this. Having said that, working with these counselors, as I tell my patients, it's all about fit. And if the kid is not comfortable talking with the specific counselor with some of the things that they're saying or anything like that, kick them to the curb and find someone else. Now, having said that, right, especially post-pandemic, it can be really hard to find somebody, or it can be a really long wait. And I completely understand that. But finding somebody with whom your child vibes is really worth its weight. WAIT and WEIGHT, both of them. It's worth the wait, if they're able to help them move forward with this. So Dr. Neinstein back in 2001 wrote an article about management of chronic illness, and he said that protective factors included positive temperament, above average intelligence, which I think is funny, social competence, supportive relationship with at least one of the parents, family closeness, and adequate rule setting by parents. For the parents themselves, self-care is so important. That includes exercise, taking breaks, either with your significant other or with friends. But having said that, beware of well-meaning friends who have completely off-base advice that's so unhelpful. Um, you know, having just being with somebody and letting and having them listen, and telling them, I just need you to listen. I don't need you to give me advice. That can be really, really important. Getting that counseling that we talked about before, and recognizing your own needs and shortcomings, which can be hard, especially when you're so enmeshed in what's going on with your child. So, where do things go wrong? From a patient standpoint, um, things can go south if the symptoms are not adequately controlled, their comorbidities are not adequately controlled. They're not used to exercising on a routine basis. And I will say that in my experience, patients who were previously athletic or athletes are very used to setting the time aside to do exercise, to do practicing physically, and they like the way it makes them feel and they want to get back to that. And I find that they tend to do better than the patients who've never had to exercise before that now have to roll this into their lives. Also seen patients who have partial improvement with a fear of discomfort. They might have improvements in their symptoms with the addition of non-pharmacologic and medication therapies, and they feel good enough, and they're scared that if I do anything else, if I make any other changes, I'm just going to feel worse again. So I'm good where I am. Procrastination, very common amongst teenagers. And then poor decision making. Remember that much gas pedal, little brake. Poor decision making can occur in the setting of expediency or fear, bad input, or having a disability or inability to make these decisions. With regards to the parents, where do things go wrong? Well, if they're controlling too much, if there are different parental attitudes toward the illness, and this is not to beat up the dads, but when there are um, different views, not infrequently it's the father who is saying, "Oh, she's not that sick. It's not that bad. This is not that big of a deal." Whereas the mom is saying, "This child is not normal, and significantly so." Um, the parental need to rescue can be problematic as well if there are unaddressed parental issues, psychiatric, medical, etc. And then if there's asymmetric parental involvement, can exacerbate these above issues and can overwhelm the parent who is doing their best to do the work. And where else does it go wrong? Social media, of course, because, there's the good, the bad, and the ugly. The good is that it allows isolated patients to maintain contact with friends and have support. That's pretty cool. And it allows for online chronic illness camaraderie, right? So the various chat groups that allow these kids to meet and compare notes. The bad, though, is fear of missing out, as well as the online bullying that can happen. That can cause serious anxiety and depression for adolescents, even in the absence of a chronic illness. And then the problematic. There are chronic illness influencers who try to remain sick to gain attention and or sympathy, which is also problematic. A lot of those kids are on TikTok. And there's misinformation. There can be misinformation about the disorder, where people promulgate an incorrect understanding of the illness, or they'll say, this worked for me, so this should work for you, right? So that generalization to everybody else, which is completely inappropriate. As well, there can be general misinformation regarding adolescence, sex, you name it, anything that can just get pushed on to these kids and they go down the wrong rabbit hole. So the risk factors in that same article by Dr. Neinstein include being a male patient, if there's a comorbid psychiatric illness in the parent, or a low socioeconomic status. So now there is a light at the end of the tunnel, and it is not an oncoming train. In our long-term POTS outcomes survey, our first of 3 papers, which we published last summer in 2025, 97% of our patients had a high school diploma or their GED equivalent by age 21. Now, you tell me any chronic illness out there that has 97% of their kids getting a high school diploma or their GED by age 21. I mean, that's pretty freaking impressive to me. 81% of patients attended college, and of the patients who had a high school diploma or GED, it was 94%. So impressive. These kids are amazing. And interestingly, these patients are often better when they go to college, and we don't know exactly why. It could be the responsibility of independence and learning to self-manage. It could be that there's a different educational method in college. You're not going class to class to class to class. You have an hour and a half, an hour to an hour and a half to 2 hours here. You take a break. It's more thought as opposed to here's the fire hose, start swallowing. You have more recovery time between classes. And there's possibly less severity as the hormones calm down in some of these patients. But that's not everyone. So the kids may still need accommodations. They may be limping through the year without any kind of accommodations. Colleges say that they're supportive, but really do check with the disabilities office when you're looking at these schools. I absolutely had a family in whom, or for whom they were looking at a specific university. They asked, is there a disabilities office? Oh, sure. Didn't look into it any further. And by the time they got to school, when we talked about doing accommodations, the disability office was like, no, they're expected to be in class like everybody else. It was problematic. And I think that it is not unreasonable if we need to take a gap year, right? So there, especially if their symptoms are not adequately controlled, and you can go ahead, these kids can take the time to concentrate on optimizing non-pharmacologic therapies, medications, and exercise to better get their symptoms under control so they can really be successful by the time they go to college. These kids may have a severe disability. They may need financial support. In our long-term POTS outcomes survey, in our third paper, which is hopefully going to be published in the next couple of months, 35% of patients and 19% of caregivers lost income over the past year, the prior year. Most of the patients lost or had to spend less than $10,000, but that's a lot. There is also SSI, SSDI, and Medicaid for workers with disabilities. In our long-term outcomes survey, 74% of patients were successful in getting assistance. But what that means is you are only allowed to have $2,000 in assets as an individual. So that can be amazingly problematic. They may not be able to work. In our long-term outcomes survey, nearly 60% were employed, although the mean age in our study was 22 years, 21.8 years, and nearly half of the patients worked at least 31 hours a week. So in summary, this is a marathon. It's not a sprint until we can find an underlying mechanism. So I think to understand this, you have to realize that we are not curing POTS. We are treating the symptoms. We are getting the symptoms under better control so that these kids are able to exercise and be able to get their symptoms further under control and also be able to do their activities of daily living. But as soon as these kids stop exercising, a lot of times their symptoms return. In fact, in our long-term outcomes survey from last summer, the first paper, 99.1% of patients were still symptomatic last month after an average duration of symptoms of 9.5 years. So hopefully we can find an underlying mechanism in the next 10 to 20 years so that we can treat it directly and make this go away. It is important to recognize that we need to be navigating the boundaries and the support. And we need to allow our kids to have increasing control and responsibility. It's important that both the kids and the parents be able to do self-care. Counseling is amazingly supportive for this. And of course, having knowledgeable and supportive clinicians is important as well. All right, I think we are at the end, and I can take questions. I'll stop sharing.
Yes, and just as a reminder, the Q&A button is down at the bottom of your Zoom screen. You can type your questions there, and then we can answer them here.
And we have mucho time.
Yes. So we have a question come in. Someone has asked, my daughter has been bedbound for 20 hours per day. Can you recommend an in-bed exercise program?
Yeah. So a specific in-bed exercise program, I'll be honest with you, I still would recommend something like the Dallas Protocol to be modified for something to do in bed. So for those folks who are not familiar with the Dallas Protocol, you can find it online if you do an internet search for Dallas CHOP, C-H-O-P, POTS. It's hosted by Dysautonomia International. It is a modification of the Levine protocol. Dr. Ben Levine is an exercise physiologist at the University of Texas Southwestern. What you see online, that I refer to as the Dallas protocol, is a modification that I made with one of our physical therapists when I was at the Children's Hospital of Philadelphia. It is an 8-month protocol. It does a combination of leg and core strengthening as well as aerobic activity. For in bed, um, recognize that the exercises start out as recumbent anyway. So you're going to be recumbent anyway. You can get like exercise pedals, like a pedaler. That's not necessarily a recumbent bike, but you can at least do that to start things going. And then the leg and core strengthening exercises can also be done minimally, but progressively, hopefully. Um, and, I think it is really important, and I say this to my patients, it's really important to recognize that in the setting of POTS, it's so hard to exercise in the absence of having your symptoms under better control. So I am very aggressive in my approach toward making sure that the patients are doing the non-pharmacologic interventions and doing pharmacologic interventions, medication interventions as well, to reduce their symptoms so that they are able to not be bedbound, so that they are able to not only do their activities of daily living, but also exercise as well.
Love that. Our next question is, the kids already want to start driving. Do you have any recommendations for parents in this situation?
Absolutely. So, and I actually say this to a lot of my patients too. Driving is one of the most complex activities that we as humans do. And here's why. We are taking data input from multiple locations quickly and processing it quickly over and over and over again, right? So you're getting information from the dashboard of your car, from people talking, from the radio, from the sound of your car, the sound of your engine, the sound of your brakes, the sound of the tires. You have signs outside that you're looking at. You have drivers around you. You have the road. You have I mean, it sounds funny, but like trees, hopefully not falling on you, but in other words, other objects that you need to be taking in. If you have fatigue and or brain fog, specifically from a POTS standpoint, it's kind of like driving impaired. And on top of that, we now have it's one thing if you already know how to drive, and driving is second nature, right? I've been driving now for 50 years. Is that right? Yeah, 40 years. And so, I've been doing this a while, something like that. It's even harder when you're learning and you're not sure of yourself. So I say to my patients, if your fatigue and or brain fog, and the parents too, if your fatigue and or brain fog are not adequately controlled, then we need to put a hold on the driver's ed, and get to that after things are better. Now, the good news is at least in my practice, and I've actually published on this as well, I've had very good success in the management of fatigue and brain fog using ADHD medications, Ritalin, Adderall, Vyvanse, Focalin, Strattera, Provigil, Nuvigil. So these are all medications that are used in that situation. And 69%, we have a 69% efficacy rate for these medications for the management of fatigue and brain fog. So it is doable.
Our next question. My now 19-year-old son has trouble describing and communicating what is happening during symptoms and flares. It's
Yeah,
so difficult to help him if I don't understand what he's experiencing. Any suggestions?
that's a tough one, right? So I think the first thing that I would do is I would actually respond to that question with a question. If we're saying that he's having difficulty describing what's happening, is that describing what's happening in the moment or describing what's happening after recovery? If he's having difficulty describing what's going on in the moment, I totally get it because he's likely not getting enough blood flow to his brain, right? If not able to um, describe what's going on afterwards, um, what may be helpful is saying, okay, well, so does it hurt anywhere? If so, point to where. Does it feel weird anywhere? Does anything feel weird anywhere? And that could be your heart, point to your chest. Does it feel weird in your head? Does it feel weird in your abdomen? Are you having pain, nausea? Um, there is a list of symptoms that I utilize, and it's actually available in one of our first papers called "Demographics of a Large Pediatric POTS Clinic." It was published about 8 years ago, 7, 8 years ago, and there's a whole long list of symptoms, and just go through the symptoms and say, "Are you having this? Are you having that?" And hopefully that will be helpful. I will say that also, it is possible, and I'm not saying that this for this specific 19-year-old, but there are some patients who have some sort of neurodivergence. And so because of autism spectrum disorder, ADHD, whatever, other developmental anomalies, they're not able to describe what's happening. I think the last thing to keep in mind for this patient is, as the parent, you may not be able to do, quote unquote, do the help, give the help to your kid that you want. And it might end up being that a clinician who is used to managing POTS patients and who is used to getting a medical history might be able to elicit a better description from your son than your attempt to do so. And that's not saying anything bad against you. It's just that, some of us have better training in doing that.
The next question, is there a recommendation of standard questions or checklist of questions to ask a college disability office? It sounds like questions should be asked prior to even applying.
Yeah. So I think so a couple things. Number one, on the Dysautonomia International website, there is a really great list of accommodations that can be used both for secondary school as well as for colleges. And so, um, and and some of these are broken out for high school or middle school, high school, and some are broken out for college. But you can use the secondary school um, accommodations in college as well. You know your kid best, and your kid knows him or herself best. Hopefully, by the time they're going off to college, hopefully. So you know what kind of accommodations they'll likely need. So my recommendation is talk to the disabilities office and say, hey, number one, do you or have you had patients with postural orthostatic tachycardia syndrome here? Have you had patients with mast cell activation syndrome? Because some patients can be exposed to various triggers that can flare their MCAS, right? Um, have you have you been able to utilize accommodations to help these kids? And the follow-on question to that is, if we have specific accommodations that my child needs, would we be able to implement those to help him or her be able to be more successful in getting through the school year? And I think that's a good start. And hopefully, my hope is, in a disability office, they know what the heck they're talking about. I think that, especially post-pandemic, um, disability offices have really gotten their act together, because so many more kids were having, at minimum, just psychiatric issues from the isolation, from being online and not with everybody and that kind of deal, being at home all the time. And so they recognize that there are uh, things that need to be done to help these kids get through.
Our next question, do you recommend homeschooling for children that have difficulty going to school?
So the short answer is yes, but um, I think in kids who are just not able to get there from here, um, yeah, doing doing education in the home, or homeschool, not homeschooling, but education in the home. Um, I mean, unless you really want to take on homeschool, I mean, that's like do it DIY, right? Um, I think can certainly allow these kids to bridge the gap when they're physically debilitated. Keep in mind, though, that I think typically kids learn better when they're in school. Typically, they also feel better in general when they're with their friends, and they want to do stuff with their friends. We want to have them do the extracurricular activities and be involved, and try as best as possible to be as normal as they can be, as they feel like they can be, with the understanding that they may not be able to get there from here. So um, I do put a large caveat on doing, home education. I think it absolutely can be helpful. And I have recommended it for a number of my patients, but obviously the bigger goal is to control their symptoms better so they can really get back to school and do it the way they want to do it.
Someone has asked, we noticed that stress is a big factor when it comes to their daughter's fainting, and it is difficult to deal with stress. Do you have any suggestions for when this happens and how to help deal with stress causing
Right,
fainting?
right. So in the absence of POTS, in the absence of syncope, in the absence of anything else, we all have to deal with stress. Okay, stress is out there. It's just we are all going to have to deal with it in one way, shape, or form through the rest of our lives. So in this case, if she is having difficulty managing stress, then I would consider looking at counseling. I would consider saying, look, what are things that we can do to alleviate this problem so that we don't go down this pathway and end up having a syncopal event, and potentially hitting our head and making things worse.
Someone else has asked, broadly speaking, how can POTS or dysautonomia lead to GI issues, and what issues tend to be the most common?
Sure. So from a POTS standpoint, so it's interesting. I see kind of two major dichotomies, or actually one dichotomy, two major directions that we can go. From a POTS standpoint, what I typically see is what is referred to as dysmotility, meaning abnormal gastrointestinal motility, right? So food goes mouth, esophagus, stomach, intestine, out. And to go from top to bottom, we have a series of coordinated muscular contractions that help move things along. In POTS, we have dysmotility. So those motility waves of muscular contractions are either discoordinated, or have decreased amplitude, or have nothing at all, no contractions at all. Okay. And so that can cause either what's called gastroparesis, where the stomach won't empty, or intestinal dysmotility, where the stomach will empty, but the intestines just don't want to get there from here. Conversely, in the setting of mast cell activation syndrome, which again can occur in the setting of POTS, what I tend to see is more a combination of no, well, actually, so let me back up. Well, okay. In the patients who have dysmotility, in the patients who have dysmotility with POTS, what I tend to see is nausea, early satiety, meaning getting full early, right? Take a couple bites, full, or not even hungry at all. Abdominal pain and constipation. Okay. From a MCAS standpoint, what I tend to see is nausea, bloating, diarrhea. So it's two different things. And so that actually helps me in my approach to how to manage these patients, because I treat them completely differently.
Do you have suggestions for how to encourage college-aged kids to take a more proactive role in their POTS and MCAS related self-care in order to improve their symptoms?
Yeah, that's a toughie, right? I mean, you gotta want it. And I think the first thing to do is not have an intervention, but just sit down and talk with them and say, how do you feel things are going? How do you think things are going? What are your goals? What do you want to do? Where do you want to be? Um, and what barriers are there? What do you think is in the way? What do you think is preventing you or stopping you from being able to do these things um, to help kind of get your symptoms under better control? You're over 18, you're off in college. It's on you, dude. So what are the things that you think are causing a problem? And in reality, I think a reasonable and totally fair question is, is there something you're worried about, something you're scared about? Um, and really try to get them to be open about it. And I completely understand. I think depending on the relationship between the kids and the parents, there may not be that closeness, right? There may not be that relationship. Hopefully there is at least some, so they have some trusting, right? And one of the protective factors that was listed in Einstein's paper was having a good, loving, close relationship with at least one parent. Having that trust is so important, because if they feel like they can trust without being, and tell what's on their heart without feeling like they're being criticized, without feeling like they're going to get in trouble, without feeling like they're going to be um, having negative consequences, that kind of thing, that can also help. And then just say, look, if you as the parent can't get there from here, do you think you'd want to talk with somebody else? If you don't feel comfortable talking to me, do you want to talk with someone else who might be able to be smarter than me? Sort of be a little self-deprecating and say, someone who might be smarter than me, who might be able to help you better, because we just want the best for you, right? And my overall response to this is that what that says to me is that these parents love their kids. I would be much more concerned if the parents didn't give a rip. They're like, dude, it's all on you. Have a nice life, and we don't care.
Someone has asked, can a TENS machine be helpful for electric muscle stimulation for the abdominal muscles? I can never say abdominal.
Exactly. For the belly muscles. So I'm not a gastroenterologist. I'm a pediatric cardiologist. And so the short answer is I don't know. I do know that there are patients who, specifically in the setting of gastroparesis, have not a TENS machine, but a surgically implanted gastric pacemaker. Now, having said that, that's after failing medications, right? I mean, you don't want to have surgery where you have an implanted device that you could potentially have an MCAS reaction to. Oh, and by the way, has a battery that you're going to need to change every 7 to 10 years. So, ideally, we use various, and there are various medications that can be used for the GI dysmotility. with pretty good success. Yeah, I wouldn't go jumping to a transcutaneous nerve stimulator straight away.
Are there certain medications that seem to work best? And is there such a thing as too much water for hydration?
Mhm. Okay, two-part question. Question number one, are there certain medications that work best? And the answer is it depends. I think we need to recognize that there is wide, and I said this in my talk, there's wide variability in the way POTS providers, knowledgeable POTS providers, care for their patients. I think there's some people who, no matter what these kids have, give a monolithic approach and say, this is what you're getting. I think there are some people who are like, well, I'm just a cardiologist, so I'm only going to treat the cardiovascular aspects of this, and I'm not going to treat the neurologic or the gastrointestinal or the joint issue, the orthopedic issues. I don't take either of those views. My approach is I say, what are your three or fewer worst symptoms that are interfering the most with your activities of daily living? And then go after that. And I have a long list of medications that I use for these various specific symptoms that are interfering with their ADLs. In fact, that is a completely separate talk in and of itself. um, but there are lots of different medications, and I would hope that the clinician whom you're seeing is knowledgeable about them, is creative about their use, is thoughtful about their use, and is able to implement them appropriately for your child.
All right, we're having a lot of really great questions tonight. We are going to try and answer as many as we can. We may not be able to answer all of them. Um, Another question we have, if a student needs to take a gap year, what are
Sure.
some recommendations for filling their time, especially if their family is off to work, their friends are all at college, what can they do?
Yeah. So I guess before we even do that, as I do, I'm going to answer your question with a question. Why are we taking a gap year? Right? Is it because of their POTS? And if it's because of their POTS, then first and foremost, we need to concentrate on getting symptoms under better control and making sure that we're exercising and that kind of thing. If we're taking a gap year for because we're not ready to go to college or because of maturity issues or that kind of thing, and they want to take a part-time job, or they want to do some volunteer work, or they want to, you know, I wouldn't let them wander around the country per se and sow their wild oats, but um, they want to be like an artist of some sort. I think it's important to find out what the kids are thinking. And again, just like I said in my talk, give them say, because if they're taking a gap year, maybe they have in mind what they're thinking about when they take that gap year. And if not, then we say, all right, at minimum, we need, not just want, but we need to make sure that we are better managing your POTS symptoms so that you can go to college next year.
Going back to this question, is there such a thing as too much water for
Oh,
hydration?
thank you. All right. Sorry, that was part one. Now part two. Is there such a thing as too much water? In our long-term outcomes survey, I had some patients who were drinking as much as 2 gallons of water a day. So as long as you are getting enough salt to balance that. So the short answer is yes, there can be too much water if you don't have enough salt. And you can have what's called hyponatremia, which means that your serum sodium level, the amount of sodium in your bloodstream, is diluted. And if it's diluted so much, you can actually have a hyponatremic seizure. And we really hate when that happens. So yeah, you can drink too much water, but by the same token, I've absolutely had patients who they need to drink that much water, and as long as you're getting huge amounts of salt, because the sodium holds onto the water and keeps it in your tank so you don't pee it out, then it's okay.
All right. This question, I have a 16-year-old with neurocardiogenic syncope.
Mhm.
What recommendations could be used to help manage these symptoms, and is it related to POTS?
Right. So the short answer is syncope, while it is an autonomic disorder, does not mean that you have POTS. I will say that in our demographics paper from, I think it was 2017, 30% of our POTS patients, of which was 708 patients, 30% of them had syncope. But just because you have syncope does not mean that you have POTS, right? So my approach to managing typical syncope in patients is, number one, trying to find out what kind of syncope it is. The majority of syncope is what's called vasodepressor syncope, in which the heart rate goes up and the blood pressure goes down. A small percentage, maybe 15-ish percent, 15, 20% of patients have what's called cardioinhibitory syncope, where both the heart rate and the blood pressure go down. And from my standpoint, therapy for that is different. But for the large majority of adolescents who have typical vasodepressor syncope, making sure you're drinking 60 to 80 ounces of fluid a day, having a salty snack, and no skipping meals tends to, I would say, help about 85% of the kids that I see. The other 15% need medication. And the medication that I have had the most success with is fludrocortisone or Florinef. It's an awesome medication. By the way, I want to contrast that with the fluid and salt needs for POTS patients. For POTS patients, I recommend 80 to 120 ounces of fluid a day. Although, as you heard me say before, some patients go up to 256 or around there. And from a salt standpoint, not just a salty snack, but 8,000 to 10,000 milligrams or 8 to 10 grams of salt a day, which is a lot, right? That's the equivalent of 2 teaspoons of salt. And so using salt supplements can be helpful, using salty foods, bouillon, canned soup, soy sauce, pretzel, saltines, pickles, that kind of thing. So anyway, getting back to the syncope. So that's my approach with syncope. And then if the patient requires fludrocortisone or Florinef, I'll usually keep them on it for 2 years, check them every 6 months, make sure everything's cool with them, they're doing all right. And then at the end of 2 years, I'll give them a trial off. And chances are really, really, really high that they'll have outgrown it and we can take them off the Florinef and then they're good.
All right, and this will probably be our last question for the night. We've had a lot of really, really great questions tonight. I know I have learned a lot myself. Um, what is the best way to find a POTS and or MCAS competent physician? And
Mhm.
how can we determine if they have the knowledge needed in order to safely and effectively treat our young adults?
So the second part of that question I'm going to answer first. And I think short of looking at online reviews and that kind of deal, it's super difficult. Just because you've got your name out there does not mean that you know what the heck you're doing. Okay. And to be fair, even though I created the CHOP POTS program in 2014, I absolutely had patients fire me. And I think one of the many reasons, at least at that time, that I had patients fire me was because I had never even heard of MCAS, much less knew what it was. So I was having patients who were still symptomatic, but you learn, time goes on. How to find someone? I mean, the easy way is, or the relatively easy way, as a lot of folks here probably already know, is that Dysautonomia International has an online list of providers broken out by state. Um, Now, just because you're on the list does not mean that it just means that you will accept POTS patients and see them. It doesn't mean that they're competent or know what they're doing or have a good bedside manner or any of the above. I wish there was a better way, short of having the interpersonal experience and sort of saying, is this person really making it for my kid or not? To figure that out. I can
Well,
do a
thank
question if you want.
Okay, we can do one more question. Um, all right, I think it is appropriate. As we are heading into October, a lot of patients experience the October slide.
Absolutely.
Any recommendations for that?
Yeah. So for those folks who have not heard of the October slide, it is a worsening of POTS symptoms that typically occurs anywhere from mid-September to mid-November. The reason for it, no clue. I have come up with multiple theories and they've all been shot down in one way. I've all disproven all of them myself because I've found exceptions to them. I'm like, well, shoot. I think, you know, making sure we're doing the basics, making sure we're doing getting appropriate fluid and salt volume, making sure we're doing the other non-pharmacologic things, including elevating the head of the bed, using an abdominal binder. By the way, an abdominal binder tends to work better than compression stockings, this is based on research from the University of Calgary. Using a cooling vest, making sure that these kids have good sleep hygiene. Um, Making sure that when they wake up in the morning, they chug 16 ounces of cold water straight away, because that actually causes a couple of different reactions in the body that helps to support your blood pressure. And then of course, making sure that they're still doing at least some aspect of exercise. I think one of the things that we see frequently in patients who are exercising with POTS is they can skip a day and be all right. But if they skip 2 days in a row, by the end of day two, they're like, oh, should have exercised, because they feel it. So making sure that they're continuing to do that. Um, And then I think that if we're still symptomatic, depending on what the symptoms are, adjusting medications appropriately to be able to combat those symptoms as well. And I think the other thing that I will say is I have absolutely seen that when patients get down the road with something like the Dallas protocol or some other exercise protocol where they've been exercising for a while, they don't have the October slide. They don't have, when they get a viral infection that otherwise would kick their butt for 1 to 2 weeks, they don't get that. They don't get these abnormal responses to stress. They are a lot more like their peers.
Thank you so much, Dr. Boris. I appreciate you so much taking your time and spending your evening with us and answering as many questions as possible as you can this evening, along with your incredible presentation. And we are just so thankful that you care so much for the dysautonomia community.
Happy to do so, and happy to help. Hopefully the answers for the questions were helpful for folks too.
And thank you all so much for joining us tonight.